Welcome to our discussion about vaccines and vaccinations. As a lot has actually changed in vaccines over the last 4 or 5 years. We've certainly seen this in the age of COVID, in the mRNA vaccines that have been available via COVID. There's also a flurry of new vaccines available or modifications to older vaccine formulations in the last couple of years as well. So let's try to map this out in a way that is logical and try to think of both the big pictures and know that the details can often be found either with a website review, there's an app that the CDC provides for vaccines. So while there's a lot of detail in this presentation, we really want your focus to be primarily on how vaccines do what they do, what kind of diseases are vaccine preventable, and have an appreciation for where vaccines are sequenced across the life cycle, who are candidates for which vaccines and not. But then the details about as far as the specific timing and space between vaccines, while we want you to have a general picture of where in the life cycle they are, you're going to find that you're going to need support with an app or another reference to help you do that when you're in practice. So our focus here, let's look at when we talk about vaccines and antitoxins, we'll talk a bit about the nature of immunity, passive versus active immunity, herd immunity, and other concepts of immunity, which should dovetail with what you learn in whatever content was delivered both prior to the curriculum and within this curriculum for immunology and infectious disease management. The first big concept is to differentiate active versus passive immunity, and hopefully you have an appreciation for this. Active immunity, and this is from a CDC's websites. In fact, almost all of the slides here or images and the content here came right from the CDC's websites. Active immunity, when we actually either have exposure to the actual disease or we give a vaccine that triggers our immune system to produce an immune response. Passive immunity is when a person is given antibodies to that disease. It can be done via the placenta or in a newborn or a fetus. And it can also be done with antibodies that are administered after an exposure or exposure risk for a person who can't mount their own immune response to that particular pathogen. The other concept that's talked about a bit in most immunology and infectious disease courses, and it's helpful to have an appreciation for, is this concept of herd immunity. If most of the people have an immune status against a particular disease, then if somebody brings in a case of that disease into that community, well, if most people already are immune to it, it doesn't spread very far because most people have an immune response. And therefore, that quells or tones down, taps down the degree to which that disease takes hold of a large community. If, however, a larger percent of the population don't already have immunity to that disease, then many more people are going to be infected. And then those people who are infected then further pass it on to others. And so it's important to look at the degree to which herd immunity exists with different conditions. That often has to do with both the scenario you think of with vaccination, but also with exposure to disease. And it really also varies the degree to which how many people in a population need to have, however you define their immunity, have enough immunity in place against the disease. That varies based on the disease and how the disease is transmitted. So how likely is it that that disease, if there's a person in the community, if it's a highly communicable disease, that people, even not immediately in the presence of that person, but in a room with that person, for example, even for a short period of time, could pick up that disease, then you need many more people in that with that immunity to that condition to develop what we consider adequate herd immunity to halt that from progressing across the larger community at bay. So important to consider that that can vary in different situations based on how close people are, how they live with each other in a rural versus a more urban area, but also the nature of the communicability of the disease itself. So the purpose of immunization is really to find a way to protect against either a known pathogen for which we can trick or trigger a patient's immune system to be able to respond to that and mount a immune response to that condition with a vaccine. Or sometimes what we target is not so much the pathogen itself, but maybe that pathogen produces a toxin or some other toxoid or something else that it's not the pathogen that you're directing the antibody against, it's whatever the toxin that's there. And that immunization process can be done in a number of different ways. Historically, it was done with weakened microbes, but in this day and age, we still use some live but weakened vaccines. We'll talk about a few of those, the big ones being measles, mumps, rubella, and varicella vaccine. But more often, we are preferring to use a vaccine or an immunization that doesn't include a live microbe at all and might either be the killed microbe or a portion of that killed microbe, or even to a greater extent with the mRNA vaccines, really a different process to trigger a very specific component of the pathogen to trigger your messenger RNA, for example, to produce a modest ability for your body to then build immunity against that particular target. The CDC and the FDA have a lot of supportive data about vaccines. I encourage you at some point to look at the vaccines website at the CDC. They also have a lot of data about safety of vaccines. That's important, I think, as a clinician to be aware of. Vaccines are highly safe in this day and age. They're pretty effective. They vary in efficacy from vaccine to vaccine. But what's important to remember is how much the vaccines that are in widespread use, we weigh the risk of the vaccine versus the benefit of using that vaccine in preventing serious disease or death. And there are some vaccines, for example, that are not widely used in a large population in the United States. For example, smallpox vaccine, because the risk for smallpox is considered quite small, and the side effect profile of the smallpox vaccine is, not comfortable for patients at the very least, and there are some side effects. So the risk-benefit ratio might render that there are some vaccines we don't use that are not part of the routine schedule for us because of the fact that they are not a major public health concern and or that the side effects of the vaccine that's currently available might be problematic. There are lots of questions you may have about vaccines, or patients or people you care for have about vaccines. Again, the FDA and the CDC have lots of responses here. So there's lots of data that's available for you, both from the FDA, the Center for Disease Control. In some cases, we'll talk through the year about the NIH, particularly the National Institute for Health, has lots of data regarding COVID and COVID guidelines, for example, and the role of the vaccine and how that's managed within the NIH's site as well. So vaccines have been around for a long time. Prior to the 1700s, there were lots of examples in early medicine about people exposing someone to a particular pathogen with the hope that the nature of the exposure, the diminished exposure that they would have early on might boost their immune system for a point later on where they did get exposed to that particular pathogen. The first sort of, I won't call it necessarily modern medicine, but in Western medicine, probably the trials with smallpox and how smallpox was addressed in the late 1700s using cowpox, something that was similar to smallpox but less virulent, would offer some degree of immunity or trigger the immune response for when the patient actually get exposed to smallpox after they've been exposed to cowpox. So, but as you look at Jenner, who is in one sense put on a pedestal as a pioneer in vaccines, there are a lot of ethics to how those trials or evaluations happened. So we would never in this day and age consider doing any such thing like this because of concerns for ethics and informed consent and what's the level of evidence that supports that risk in whatever population. But I think the other thing is you look at the evolution of vaccines, you can certainly, we've all lived through the COVID uh, pandemic, which still persists. Uh, and you might remember the nature of how we, in pretty short order, identified the pathogen and within really just over a year had vaccines available for reducing its risk. And so, in times of epidemics and pandemics, we might sort of look at, before the FDA has a chance to fully approve the vaccine, they had emergency authorization for the use of vaccine with a body of data that was robust enough for people to feel confident with. Um, but in the midst of a pandemic, sometimes vaccines get rolled out early in the interest of major public health benefits. So let's look at some definitions here. There are concerns for vaccines, which identifies or contains either a whole or a portion of a microorganism or some other component that will then trigger the person's own immune system to make antibodies directed against that point. Um, Killed vaccines versus live vaccines versus components versus mRNA vaccines, they are all somewhat different, but the biggest differences I think that you need to be aware of are the live attenuated vaccines, the vaccines that uh, are really not uh, killed virus, but have some ability to transfer disease. And in those circumstances, I think we need to be careful about whether somebody who gets exposed to a live vaccine has an immune system that can respond to that. So you'll find that for the few live vaccines we have, that's measles, mumps, rubella, and varicella, we generally avoid using those in women who could be pregnant and in individuals who have an immune system that is significantly compromised. We'll come back to that. But so you really want to know what the live vaccines are, which I pretty much just said, um, versus the remaining vaccines that are there and where they fit for contraindications. Toxoids are a little bit different in that the target here with a toxoid is to develop immune response against the toxin that's produced by a bacteria rather than the bacteria itself. Um, we differentiated active versus passive immunity. Important for you to understand that. And we don't spend a lot of time in this block, but we will throughout the year periodically talk about the administration of immunoglobulins. So, for example, someone who doesn't have an immune response yet, doesn't have antibodies already to a particular pathogen, it might be that they're, if we give them a vaccine, well, the disease may take hold faster than the person can produce an immune response via the vaccine. And examples where we use immune globulin that is very specific to that pathogen are rabies immune globulin in a rabies exposure and hepatitis B immune globulin. We also have a hepatitis A immune globulin we can give. In COVID, there are antibodies, monoclonal antibodies that can be used, although those have to be very specific for the strain of COVID. Early in the pandemic, we had such in pretty wide use of them in people who are immunocompromised. But the virus has, in a sense, evolved so that those antibodies that were available at the beginning of the pandemic probably aren't quite as effective now. We have, in traditional vaccines, we have weakened microbes, we have killed microbes, as we alluded to, we have inactivated toxins. We have some vaccines that are subunits. They are acellular, for example, acellular pertussis. We found that in an earlier version decades ago of a pertussis or whooping cough vaccine, we used the whole pertussis killed, and there were more adverse effects, more fever, more pain at the injection site than if they just found a component of pertussis and not the full cell killed. That would also trigger an adequate immune response, but not trigger this reaction to it. So there are subunit vaccines that are available. There are also vaccines that add a coating or a conjugate or something else to the vaccine to make it more recognizable for the immune system to then produce antibodies. And this is particularly true in younger children who have not developed a full immune response yet. You may kind of look at the immune schedules, the vaccine schedules we'll look at in a bit, and kind of ask yourself, well, why do we sequence the vaccines the way we do? And part of that is based on, what's the exposure risk during that window of time for the newborn or the infant or the child, but also what's the concern for patients who have a risk for in their immune response, have a risk for not producing enough of an immune response at that point, at that age. And so sometimes we find that some vaccines are administered not at 2, 4, and 6 months, but after 6 months or at a particular window of time that is specific for when that vaccine is effective. And we sometimes have used conjugate vaccines to kind of allow us to sort of move forward. I encourage you to look at the mRNA vaccine video that's going to be posted. And this particular video is quite effective at talking about how the newer mRNA vaccines work, what their concerns. They try to answer some concerns that questions have about whether or not it alters your DNA, which it doesn't. You can sort of look through the vaccine and the vaccine video and see that for yourself. But for the most part, the first mRNA vaccine widely available was the COVID-19 vaccine, and understand that what the body looked at, what the body sort of targets in the is the spike protein on COVID, and so we look at that developing an antibody against that spike protein involving messenger RNA. The vaccine, which is made of mRNA wrapped in a coating to deliver it to the body in a way that allows it to be effective. And then it really works at triggering then ultimately the immune response to produce antibodies against the spike protein. I alluded to a couple of principles in epidemiology about how does clinicians determine the vaccine efficacy and effectiveness. And this gets much more into details in epidemiology and public health. But what I think is important is to recognize that the ability of a vaccine to be effective at preventing a disease depends on a number of factors. It depends on what's the risk among unvaccinated versus vaccinated people, what's the difference there. It also has to do with what's the nature of how the pathogen is contagious, what's the route of achieving an infection, what counts for an infection, and the degree to which that happens whether you're vaccinated or not. In calculating vaccine effectiveness, there are formulas here. not critical that you know these, but have an appreciation that they're not perfect. And with each of, or most of the vaccines at least, that we'll go through specifically here, you'll get the sense that some of these vaccines, their effectiveness rate is not as stellar as you might think it would be. And we'll talk about that, where there are other vaccines that are very highly effective. And so we'll kind of look at the differences among those. And that would, that gets into the point of the risk versus the benefit of how you approach which individuals get which vaccines. There are a couple of other things that, in general terms of vaccinations, that I think are important to remember. I think that we have certainly a lot of individuals in this age now, it's become quite a political point to be anti-vax for a number of people. And for those of us who have gone through in healthcare windows of time where we didn't have vaccines for life-threatening diseases, and these are now vaccine preventable diseases, when you see these diseases crop up again because there is an inadequate vaccination in a population, it's really quite heartbreaking for us as clinicians to see this. The World Health Organization, in conjunction with the CDC, have had a lot of data on this, but for the most part, if you look at this statistic, it's estimated that about 2.5 million deaths among children younger than 5 years every year are prevented by vaccines. And yet we still have vaccine preventable deaths going on all the time. So we can do better, but vaccines prevent deaths and they prevent significant morbidity as well. We'll talk about that when we talk about the diseases with vaccines in a bit. Other things to think about is the side effects that happen with vaccines. They do occur. They depend and vary on the vaccine. I think everyone who's gotten vaccines and being in healthcare, there are a number of them you have to get. You pretty much know that very commonly you're going to see a local reaction, particularly a sore arm, is very common for the first 12 to 24 hours after vaccine administration. And varying vaccines have different systemic reactions. Very commonly, you'll see fever, headache, body aches, fatigue. They're usually mild, sometimes they're moderate. They can happen a day or two beyond the vaccine. Usually by day 2 to 3, they're better. People think, oh, gee, I had, you gave me the vaccine, the flu vaccine, I got the flu. You gave me a COVID vaccine, I got COVID. No, what that reaction often is your body's really working hard at mounting an immune response, and you feel pretty miserable because of that. But you're compared to the underlying disease that it prevents, those are pretty mild risks compared to what the disease in its full-born situation could actually do. There's a lot of vaccine safety monitoring that's happened over time, over years. When the COVID vaccine first became available, there was a whole program that people, and a lot of people participated in, maybe you did as too, that would do, if you agreed to participate, I know I did, you would get you would sign in with an app, and then every couple of days after your dose, and then weeks after your dose, then months after your dose, you'd occasionally get a text that would ask you to complete a very short questionnaire about, are you having any adverse effects? Have you had the disease in question? And it helps, that body of data helps assure the degree to which there might be a new problem that hadn't been discovered in earlier studies or not. So the CDC was pretty slick at doing that kind of surveillance with the COVID vaccine. And they probably, when new vaccines come out, they do a very similar kind of approach as well. There is no such thing really as autism with vaccines. That's been widely a big concern, but it's been pretty much been largely disproven. So vaccines don't cause autism. They don't contain ingredients that could cause autism. There are other sort of idiosyncrasies with vaccines. You want to pay attention to the degree to which the site of injection, the length of the needle, the frequency of re-administration, how to monitor things. How vaccines are administered varies somewhat from vaccine to vaccine. The site of injection, uh, and whether or not you can give two vaccines the same day or not. You want to look at the specific data for each vaccine. But here's a set of data that indicated that needle length might make a difference, that the site of injection based on age, deltoid versus gluteal versus somewhere else, are sometimes is important for looking at response as well. There are a lot of vaccine preventable diseases that are around, and so I think as a clinician, you want to be aware that there might be a responsibility that you have as a clinician to report to your local or state public health department if a particular new case of a vaccine preventable disease, for example, measles, comes about, that there's a way that that can get reported to the Department of Public Health and ultimately to Center for Disease Control. Because it's important to survey if there's an outbreak of vaccine preventable disease in an area. That's important public health information to kind of move along. There are lots of different ways to find what's available, but depending on the state you practice in, here's one website. There are others as well that help you identify what are the requirements for immunization and reporting of vaccine preventable diseases state by state. Some of the last things here before we go into specificity with vaccines, this done in adult populations a few years ago. But what's in my mind quite sad about this is that of the percentage of the population who are candidates for particular different vaccines listed here, and each line is different, you'll notice that even with the best adherence, we have a large number of patients who are not vaccinated according to the standards, and some vaccines quite a bit lower in their percentage than what they could be based on what patients could get. So it's pretty sad to see this. I think what's also, as of early 2024, we're now seeing this past season here in January, as I'm recording this, we're looking back to the rates of influenza and COVID vaccination in the population at large for this winter season has been lower than expectations have been, and probably the lowest COVID vaccination rate we've had since the onset of the epidemic. And we're seeing many more cases of COVID in local communities, in part related to that. It's not that the vaccines may necessarily always prevent the disease, but they can decrease viral burden. They can pretty much reduce for COVID, for example, they reduce both the severity and duration of of COVID outbreak. They reduce viral burden and spreading to others. So they have some public health benefit, even if they don't absolutely prevent you from getting COVID. When you get COVID, if you do, your case is much milder with less viral burden, significantly so, and less likelihood of transmitting it to others. So we also see that the dips in vaccine coverage are also related to different populations, often individuals who have less access to care. It's problematic to see if they have lower access to care. They often are less vaccinated, but there are other factors as well. It might not just be access. It might be issues of trusts in that particular community and or other factors. But we see that there are discrepancies, healthcare discrepancies in vaccination, like there's healthcare discrepancies in virtually every aspect of medicine. So as you think of this, you want to really try to do your best to get your hands around what vaccines are critical for patients to receive and how can you approach them in a non-judgmental way to encourage them to take advantage of that. Each state, as we alluded to, has their own vaccine preventable reporting systems, so you want to be familiar with what they are in your practice area. As far as other factors, some vaccines and allergic disease, there was some question that vaccines may affect the development of atopic dermatitis or some other allergic disease later in life, and that's been largely refuted. The Center for Disease Control has new schedules they print every January they update, and they might update them mid-year as well. That's particularly true when some change has happened. For example, it is pretty common that usually around August, the CDC will update their recommendations and formulation for this season's influenza vaccine. Likely that they will also include COVID vaccine updates whenever they happen, and then any other outbreak where a vaccine might be available or a pandemic is evolving or an epidemic is evolving, they may have varying recommendations beyond that once a year January guidelines. But those can all be found from the CDC website. If you go to the CDC website, that you can download those specific schedules, both childhood, adolescent, and then the adult schedules. There's also an app we'd encourage you to look at as well. The app is downloadable to your mobile device, and we very much encourage you having that. What's specific about and nice about this app is that it's continuously updated. Once you know how to navigate the app, when you're in practice on the fly and you're trying to determine if an individual is responsive to or a candidate for a particular vaccine, when you go to this app, it becomes very clear who's a candidate, and then you can adjust the app to, well, what if this person's pregnant? What if they have diabetes? What if they have some other risk factor that affects their eligibility for a vaccine or not? That's all your ability to modify that recommendation is done right in the app. So that's really helpful to have. So knowing that you have that tool available and other tools available, there are lots of details in this presentation for which I think it's more important you know how to navigate these systems and have a general idea of where these vaccines fit. What are the big picture items or focus that you have for these? Like, how are they generally sequenced? And what are the big concerns you think about with each vaccine and the disease it's preventing? And then just kind of move on to the details with data you'll have in your hand. Finally, for this first review, there's the pediatric vaccines from age 0 through 18 years of age. You can go to the website. You'll see they often include these tables. Here's one. It's a little difficult to see. It's a little easier to see it on the next slide, and even then it's kind of hard to see. But you can also see this on your app as well. And they have a set of tables from birth to 15 months, and then from 15 months to 18 years of age, and then different vaccines and how they're sequenced. So you should have an appreciation for which vaccines are first out of the chute and which ones are given sort of later on in pediatrics, adolescents, and ultimately we'll talk about in adulthood in a little bit. Here is the classic standard table 1 for children and adolescents about, again, the same data as you saw in the prior slide, but it's a table that indicates, hepatitis B vaccine and RSV vaccine and which vaccines happen at 2 months and 4 months and 6 months, and which ones happen later on, and how they are sequenced. So important to have an appreciation for those. If you have a situation where someone falls behind in their schedule, which is very common, the CDC has guidelines. They also have guidelines in general in adults, but it's much more formalized in pediatrics. When you're in your pediatric rotations, if you happen to go into family medicine or pediatrics primary care, these vaccines and their sequencing will be quite sort of familiar to you in practice. The other thing that's nice about the CDC tables in their table 3, this one is pediatrics. And again, you kind of get the gist. If there is a little teddy bear on it, that's pretty much a pediatric focused situation, um, that you'll see that these list the contraindications in red, the relative contraindications in orange, and it's pretty much okay in a sort of golden yellow, and then some other related color coding down the bottom here as well. But the big things are, can you use it in pregnancy, can you use it in individuals who are immunocompromised to varying degrees. And what you'll notice is that those vaccines that have a live component to them, there is a live influenza vaccine we are concerned with in that regard, as well as measles, mumps, rubella, and varicella vaccine. You'll notice that those vaccines, because they're live, are contraindicated in pregnancy and in individuals who are immunocompromised. Lastly, here are the adult schedule tables. And for these slides, I've included a 19 plus symbol if it's really pretty much focusing on adults. And this schedule is both in a smaller window here, but a larger table 1 that looks very similar to what you're going to see in the pediatric slides as well, pretty much with the breakdown of 19 to 26 years, 27 to 45, and beyond, and then over the age of 65, with varying criteria of who are candidates for which vaccine. And similarly, for immunocompromised individuals, which are the vaccines that you would be concerned with because they have a live component to them that would be riskier to use in individuals who are pregnant or immunocompromised.